The Neonatal Neurocritical Care Program in Calgary operates with a singular, unyielding objective: driving severe intraventricular hemorrhage, catastrophic bleeding within the brain's ventricular system, to absolute zero in extreme preterm infants. Historically, intensive care units relied heavily on homeostasis. Homeostasis is the concept of maintaining a rigid, unchanging internal physiological set point, regardless of external stressors. But a neonatal intensive care unit is not a flat track. It is a highly hostile terrain packed with extreme experiential and physiological stressors. Survival in this harsh environment requires allostasis. Allostasis is the brain's ability to achieve stability through change, dynamically adjusting its physiological output to meet immediate environmental demands. The primary pathophysiological battleground is the subependymal germinal matrix. This dense, highly fragile vascular network in the developing brain lacks the capacity for autoregulation. Forcing a biologically fragile neonate to maintain rigid homeostatic set points without recovery periods triggers toxic stress, overloading the infant system. Clinical protocols must be redesigned as an allostatic buffer, proactively absorbing environmental stress for the infant. Just as a trail runner proactively shortens their stride to navigate a steep incline, medical survival depends entirely on dynamic responsiveness to the patient's immediate physiological cues. Failing to pace interventions to the infant's immediate terrain subjects the developing brain to catastrophic structural failure. In a group run, an erratic leader with a choppy cadence creates an accordion effect, forcing the trailing runners to violently brake and accelerate. Inside the premature infant, uncoordinated, reactive clinical interventions, like rapid fluid boluses or sudden airway suctioning, create an identical, chaotic physiological ripple. These sudden interventions cause massive spikes and steep drops in cerebral blood flow. Because the preterm brain lacks autoregulation, these volumetric surges transfer direct mechanical force to the microvessels, rupturing them and hemorrhaging into the ventricular system. The Calgary program solution is the strict protocolization of hemodynamic and respiratory management to completely eliminate erratic clinical stimuli. Standardizing mechanical ventilation prevents iatrogenic shifts in carbon dioxide levels. This directly controls cerebral vasodilation, dictating exactly how wide those fragile blood vessels open. Establishing a smooth, protocolized physiological stride neutralizes the internal accordion effect, effectively removing the primary mechanical trigger for hemorrhage. A rigid one-size-fits-all protocol fails because extreme preterm and term infants operate at vastly different developmental stages. It is like expecting a tall runner and a short runner to share the exact same stride length. Quality improvement methodologies must strictly stratify care data and intervention cadences based on the exact gestational age of the infant. In a running squad, leaving physical space between runners provides a vital safety buffer, allowing trailing members time to react without colliding. The clinical equivalent of this spacing is the strict enforcement of minimal handling protocols by nursing and medical staff. Premature infants are easily overstimulated by standard tactile and auditory noise. Routine physical touching causes dangerous fluctuations in systemic blood pressure. Enforcing strict midline head positioning for the first 72 hours ensures optimal venous drainage via the jugular veins, preventing spikes in intracranial pressure. By clustering mandatory care procedures, the staff provides the infant with extended periods of absolute physical space. Minimizing handling actively shields the infant from stress-induced blood pressure spikes, giving neuroplasticity the undisturbed room to heal. Drafting in a running squad reduces wind resistance. The pacer absorbs the drag, saving the group's energy. In the intensive care unit, standardized evidence-based neuroprotection bundles serve as clinical drafting. Utilizing pre-established order sets dramatically reduces the cognitive load and decision fatigue for frontline nurses and doctors. This structural efficiency allows teams to focus on marginal gains, aggregating tiny, non-pharmacological adjustments, like delayed cord clamping and minimal handling, rather than massive disruptive interventions. Before the care bundle, use of powerful inotropes, rapid fluid boluses, and opioids dropped dramatically. This massive reduction in interventions resulted in a 66% relative risk reduction in death or severe brain injury. Aggregating marginal gains and reducing cognitive load directly translates into the biological preservation of the neonatal brain. Entrainment is the natural athletic phenomenon where runners unconsciously sync their footfalls to match the efficient rhythm of the surrounding group. A high-functioning neurocritical care unit achieves this silent sync by intentionally dissolving traditional medical hierarchies. They democratize diagnostics, training frontline bedside nurses to independently perform point-of-care cranial ultrasounds and continuous EEG brain monitoring. This shared capability eliminates diagnostic bottlenecks, allowing the entire multidisciplinary team to continuously monitor for subclinical seizures or expanding hemorrhages. When every practitioner shares the same diagnostic rhythm, the unit achieves continuous allostatic responsiveness, instantly matching the infant's changing physiological terrain. True quality improvement cannot remain permanently siloed within highly resourced academic tertiary care centers. Premature infants requiring emergency regional transport face an extreme allostatic load from uncontrolled vibrations and temperature fluctuations. Clinical teams addressed this by applying continuous plan-do-study-act cycles directly to the logistical operations of the regional neonatal transport service. Through continuous adaptation across transport service hubs, median urgent launch times dropped from 35 to 17 minutes. Combined with outreach education, this acceleration halved the rate of death or severe brain injury for transported neonates. Aggressively scaling the iterative methodology across entire transport regions effectively extends the neuroprotective umbrella to the most vulnerable populations. The foundational philosophical tenet of the Calgary program asserts that brain injury is not a death sentence. The infant brain possesses its own biological growth mindset through neuroplasticity, making it intrinsically capable of reorganizing neural networks and bypassing damaged tissue. If the clinical squad rigorously paces the environment and acts as a perfect allostatic buffer, the premature brain will utilize its inherent plasticity to try again, successfully wiring itself for long-term survival.